Tony, thank you very much for the kind introduction, and to the other editors of the Journal of Pediatric Urology, Ryman Stein and Tony Caldemone, as well as the managers of the Journal of Pediatric Urology Company, in particular Philip Ransley, Stuart O'Toole, Carolyn McDonald, and Stephen Griffin, Tash Allen from Elsevier, who is our partner in the Journal of Pediatric Urology, and most importantly to David Frank, the founding editor of the Journal of Pediatric Urology, and after whom this medal that I've just presented is named. I have nothing to disclose at this time. You can see here what the learning objectives are, and hopefully we can discuss some of these at the end of my presentation. I think most importantly, when we look at our lives, it's always a balance. We talk about work-life balance, but we go out throughout our lives looking at risks and benefit. And what that eventually translates to it is, what are we giving, what are we getting back, and what is the return on investment? This requires, in all aspects of life, whether personal or professional, for us to be adaptive. How can we change? How can we relate to the environment and the cultures around us that impact us? I had, in essence, to adapt to this talk today. My computer deleted 100% of all my PowerPoint presentations, including the one that I was to give today, every PowerPoint and every photo over the last 30 years. So I thought I'd be standing in front of you giving a TED Talk. Instead, I adapted. I've created a TED Talk, but the Ted Lasso Talk. And perhaps some of the lessons I've learned along the way, and also from Ted Lasso, and how these may impact how we relate to healthcare and leadership. If I go back to surgical training, the way I was brought up was still in the old Hallstedian philosophy, where it was a pyramidal system of choice within a residency program. There was no match in urology. You ended up going into general surgery, and if you were one of the chosen few, you escalated to the top and ultimately graduated as a chief resident in general surgery. However, since 1992, all programs, at least in North America, have had selections based on a match process. So you match into urology or orthopedics, whereas in the past, it was many of the people who weren't able to escalate up the pyramid in general surgery. When I was in medical school, unlike today, I didn't even know what a urologist was. Even as a surgical resident, I did not have any urology rotations. Who would have thought today in 2025 that I'd be a pediatric urologist? Interestingly, within 5 years of my finishing my surgical training, I'd essentially become a dinosaur. I had nothing to do with general urology or what people learn today. If we even look at pediatric urology, what the bulk of our practices today are composed of are essentially what we've been able to raid from other specialties. Penile surgery, which was owned in the past by plastic surgeons, and groin and testes surgery, which was in the realm of the pediatric surgeons. We thought that by creating our own subspecialty, that we would be welcomed by our colleagues in general urology and pediatric surgery and plastic surgery. In reality, it was a fight. It was not something that happened easily, and it took a lot of time before we became a recognized subspecialty. And I think it's important to recognize that all of us who are involved in the care of pediatric patients, especially within surgery, are there not to establish a monopoly, but to take the best care of patients that we possibly can, and that is to establish a standard. So how did we even get there? Again, it's about change. It's about adaptation. And the reality is Frank Bicknell from Detroit got together with some of his friends who had an interest in pediatric urology. How did this happen in 1951? Well, Frank's brother-in-law was president of the American Academy of Pediatrics and said, maybe we'll have a good time in Chicago. Bring along some of your friends. And that's how it started, essentially as a thought. not as a long-term goal and with what we've been able to establish today. By 20 years later, 2 decades later, the section of urology was officially formed within the American Academy of Pediatrics. And within 4 years of that, the AAP member became part of the American Board of Urology. So it was really a quarter of a century before we became part of established urology. It then took another 20 years before Barry Bellman, who really was never short of words, was able to really push as an elder statesman or one of the icons in pediatric urology, the fact that we were different from general urologists and we had become the standard of care, the standard of excellence for the best care of children. In doing so, we also had to understand that the American Academy of Pediatrics was one of our big supporters that allowed us to really move towards ACGME accredited fellowships. And within a year of the AAP adding that requirement for us to become a fellow of the American Academy of Pediatrics, the Society of Pediatric Urology also mandated the completion of a fellowship in order to have membership. I was fortunate to be president of both the Society of Pediatric Urology and the American Academy of Pediatric Urology, which were part of the membership group of the Pediatric Urology Coordinating Council that worked with our colleague Gil Rushton, who's here today, along with members of the American Board of Urology, as we pursued the quest for sub-certification in pediatric urology. And again, by 2006, that wish, that dream, that ability to adapt and change had taken place, where finally we were recognized as something that was unique and something beneficial, and hence had our name and our future as part of the American Board of Urology. So the first certificate of added qualification was offered in 2008, and I think most of us in this room are well aware of the requirements in order to continue to maintain our certificate of added qualification. So getting back to Ted and what we've learned from him, and many of you I'm sure have seen the program, is he always came up with clever thoughts. Some of them we would scratch our heads, remain puzzled, and some of them would be echoed by his colleagues and other coaches. Well, how is Ted like many of us in this room? Ted was an American football coach, not a non-North American football or soccer coach, and he had to adapt. He had to change, becoming a coach in a new system when he accepted the reins of coach of Richmond FC. Well, how did I get there? How am I like Ted? I was born in Winnipeg, Canada, and I'm a proud Canadian as well as an American. And who would have thought again that I would have left my small home in Winnipeg where everybody lived at home during college, married the girl next door, and never even thought of leaving our own city, let alone country. Like many of you in this room, I had an intended path. I thought I'd be somewhere and it'd be an exponential or linear growth, but in reality, we have ups and downs and we have to change. And our reaction is so important in how we deal with the impediments that occur along the actual intended path. This was my medical school quip that was in our yearbook. And interestingly, it's funny that I am finishing my career here at the University of Minnesota. And I did indeed go to Los Angeles County Medical Center where I had hoped to become a trauma surgeon. Well, before that, I had hair, believe it or not, and I thought I was going to be a rock and roll star. So that dream too was circumvented by reality. I've held lots of positions over the last several years, and as a result, I've got to see the world from different perspectives. I've been able to criticize and critique many of the things that I've been involved with, and hopefully, based on that, rather than being negative and just condemning situations, trying to take the powerful positive route and make changes. This has required resilience, both in my professional and personal life. Who would have thought that my middle child, Alex, who I'm holding here on the left, would have developed at age 8 a brain tumor and would have died on Christmas Day 2002? Who would have thought 10 years later that I would be lying in bed putting on 45 pounds after tearing my quadriceps and not being able to walk independently for over a year and a half? Many of the things in my life changed, and this did require resilience, and the desire to understand my situation and go forward. So life does have its ups and downs, but it didn't become a flat line for me. It became something where I had to say, life goes on. I have an opportunity. I can't look at something as being defeated in this situation. This required, again, the ability to adapt, the ability to change. I had to ask myself along the way, whether it's personal or professional, just like Ted Lasso did, is this really normal? Is this what it's supposed to be about? Or is there some other way of looking at the situation and potentially improving it? So, Ted, if we take a look at him with regards to healthcare, there's the pre-TED and post-TED, where, like many of us in our own situations, we look at outcomes. We're competitive people. The institutions that we work for are inherently competitive, and we forget that we're people persons. This is the way we should be brought up, that we should be focusing on people. And that's how we have to drive our cultures in order to make them more meaningful. This can't be done overnight. It requires steps. It requires learning. It also depends on mistakes and learning from them. Healthcare is complicated, and it is more complicated every day. When I started as an academic surgeon, you had to be a triple threat. You had to be a clinical surgeon, an educator, and a researcher. Now, we drive much of the economy of the systems in which we work, and we're looked at as drivers of RVUs. So there's opposing forces compared to what the stimulation to drive us to become academic surgeons in the first place, or even clinical surgeons, has become as to what occurs today. So medical school, when I was there, you had to know every step of the Krebs cycle. You can see on this chart of biomedical knowledge, from the time of William Osler to the time I was in medical school, biomedical knowledge wasn't changing that dramatically. But look what's happened ever since. Medical knowledge has gone from doubling every 7 years from the time I started residency program to doubling every 2+ months. How can we keep up with these advances? How can we stay current? This is certainly a challenge today. Fortunately, we have many things that who would have thought would be there today, like our iPhones beside us and having our mini computers right in our fingertips. Who would have thought we'd become so knowledgeable and knowledge would increase so greatly that the number of subspecialties would have increased the way they have again since I started, from 40 to 150 different specialties today. More than that, it's an aging population. Again, this isn't all that relevant to pediatric urology or pediatric care, but look at the number of people who are constituting the aging population and how it's going to increase by 2050. With increased longevity comes new diseases or increased prevalence of diseases known to us, such as diabetes, as you can see here. As a matter of fact, maybe Aldous Huxley said it correctly, that we made such tremendous progress within medicine that there is hardly a healthy human left. We're only going to be sick ones who continue living on and on. And we have to ask ourselves, with all these changes, is this what the patient wants? Is this what their family wants? Are we doing the job that we thought that we could do, and are we doing it well? And this is really the culture that we live within and how it impacts us because of the changes that occur. We have to have that shared blueprint or mental code within us if we're going to proceed forward. We have to understand that the culture shift is important. And again, getting back to that focus of Ted Lasso on the people rather than the system and the outcomes. Have we become and are we becoming undervalued, replaceable widgets within the system? What our colleague Rama Jayanthi in Columbus, Ohio has said, the relationships that we've had with our families and our patients, will these continue? Or are we in a position where it's an ongoing assembly line of unfamiliar faces and just numbers that bypasses as time goes on, where we're sitting with our backs to the patients, typing in information into the computers with less eye to eye and smiles with regards to our contact? And this is in the realm, again, of increasing knowledge and other disruptions that aren't in our control, whether it's technological or external influences such as the COVID pandemic that occurred. Healthcare, any way you look at it, whether it's a vocation, whether it's a hobby, no matter what we do, is very dangerous. And we have an impact on lives lost per year. The bulk of the errors that are made within medicine are the results of miscommunication. And if we take a look at it, behind heart disease and cancer, medical errors continue to be the leading cause of death within North America. So we have to believe, if we feel the culture needs to change, how can we involve ourselves? How can every one of you be a leader rather than just follow mandates or policies and procedures? We have to understand that it isn't easy. We live in this complex system of silos, and we have to not necessarily bring all the silos together, but at least establish ways or walkways between the silos so that we can communicate better with one another. Oftentimes, especially for within big systems, there's metrics that are set. Who's setting them? Is it you in the audience? Are we saying what we need to do for the best care of our patients? Or are we following something that is no different than what a geneticist or a pulmonologist might be following, because this is the metric that your system is establishing? So we have to ask ourselves, are the expectations reasonable? Are the people in the C-suite even aware of what's going on the front line? And are we at the front line just there complaining about it, or are we taking action so that there's understanding and communication, not just this vertical hierarchy where we lack the influence with what's going on? If we take a look at it, workplace culture is not easy to change. It takes years to do, and the larger the organization or the more entrenched the culture is, the more difficult that is to occur. And oftentimes there's a honeymoon phase, but eventually things tend to drift back down before we finally get into a more established status quo. The impact, however, is on us. It's an emotional roller coaster as things do change along the way. So if we take a look at everything I've said up to now, complexity is really the active status of what's occurring in healthcare. Everything is combining together and it's additive to increase this complexity. So how do we adapt? Well, traditionally we followed what we called technical leadership, where we tend to follow things that have done before. We bring in external consultants. We tend to repeat the same processes that we have been before. But Ron Heifetz at Harvard has suggested that maybe for complex problems, we have to be more adaptive in how we deal with them. We have to look at things differently. We have to ask ourselves, are we really following the missions that help to guide us? Our mission within the AAP or our mission with the American Urological Association regarding highest standards and wellness. If we take a look at it, we have to be curious. So again, just like Ted Lasso said, not judgmental. We have to understand the problems, diagnosing what's going on. We have to be patient or person-centric and be curious, know what they really want, understand why they may be happy or unhappy with what we do. And again, by doing so, it means getting together in a safe environment, just like Ted did with the Diamond Dogs. We're competitive. We're type A personalities in many cases. We've competed to get into the best colleges, the best medical schools, the best residencies, get the best jobs. And when things don't go perfectly, we tend to be our toughest critics. But we also are in a challenging culture because we tend to be punished for what we do. And Lucian Leap, a pediatric surgeon who used to be surgeon in chief at Tufts Floating Hospital, said the greatest single impediment to error prevention in the medical industry is that we punish people for making mistakes. We're human. We're not gods. Things that occur, despite what we try to do, impact the patient. And the Institute of Medicine came out with two publications starting in 1999 of To Err is Human and Crossing the Quality Chasm, which essentially reiterated that good people are working in bad systems, and we bear the brunt of the punishment. Medicine is trying to emulate highly reliable organizations. Those are organizations that operate in a complex, high hazard domain. And the goal, obviously, is to prevent catastrophes. Within those environments, we have to realize the behavior has different realms. There's human error. Again, we all make mistakes. There's at-risk behavior where sometimes we think we're taking a shortcut, but not necessarily doing something that's totally reckless. We can't hold people blameless, but we can't blame and shame them either. So is there something in the middle, something that Marx has described as the just or fair culture? And by doing so, by examining human error as opposed to the other extreme of reckless behavior, can we then identify ways of dealing with the situation and that individual, either by consoling them, coaching them, or yes, some do require punishment. We're also, as surgeons, very dogmatic. This is the way I learned it. This is the way I was trained. This is the right way of doing things. And therefore, I must continue doing it this way. But that's not the way it is. We'd still be doing things with big open operations, not going to minimally invasive small incisions or laparoscopic or now robotic surgery to deal with problems. Why does hypospadias surgery seem to change almost every week? Rick Ehrlich used to quote Stuart Brand to me all the time, and he used to say, once a new technology rolls over you, if you're not part of the steamroller, you're part of the road. But you can't just accept everything right off the bat. We're all individuals. We're all different. We have to deal with things differently. And again, that's what Ted did in the context of a team by investing in the team's growth. He had to rely on the right people. He had to choose those who were within the organization. He had to decide who could be a winner, who were his key people to make the others listen. And again, if there are those who are completely negative despite their abilities, are they somebody who could really still be part of that team? So there has been a paradigm shift within healthcare. When I started, we were by far the captain of the ship. What we said held true. I no longer can take care of complex patients. We have hospitalists, we have intensive care specialists, critical care specialists. It's become a team approach to providing the best care for the patient. We have our allied health people, we have our MAs, we have all sorts of people that help us to do a better job, but we have to be able to communicate and work with one another as a team. And this depends on trusting one another and really having our own self-awareness and self-regulation, which was what we call emotional intelligence. We have to help those who we work with become the best at what they're doing. That's the role every one of us could do because we work with other people. It's making our team stronger by making the individuals we work with stronger. And yes, management is important, but leadership is really about doing the right things, not about always doing things right. And this requires, if we're dealing with people, to understand that when a new idea comes out, okay, so getting back to the Stewart Brand quotation, are we early adopters or innovators, or are we the ones on the rapid uptake, the early majority or the late majority who are then able to accept a new idea? And there's always going to be the bottom 15 to 20% who are going to be the laggards or the naysayers, the ones who say no, no, no. That's not the people who you want to deal with right away. You want to get the people on that up curve, the 66% in the majority who are going to be able to come up and adapt to the new idea, to accept the idea as part of an ingrained culture. It's funny, I've taken the Myers-Briggs test several times, and every time I become an ENTP. When I've done these tests, especially in big groups, I've been shocked by the number of people who might be, who I conceived as being extroverts, and they're really introverts, how many people react differently. So, are they hearing things and processing things that I'm saying the same way as you over there and you over there might be doing? So it's very important to us when we're coming up with new ideas, with changes within a culture, to identify how people might be able to adapt. Is it because they have the knowledge? Is it because they have the skills? Is it because they have the attitude and behaviors? And if they don't, how can we impact those to give them those abilities? So, in order to get ultimate success, we have to engage people. We have to do so by communication. And then we have to celebrate it. We have to say thank you or congratulations or nice job or whatever it is, because we want things to be sustainable and we want that culture to be something that is permeated. So, what did Ted do and what have we talked about so far? He talked about the importance of having a shared mental model, again, that culture, that blueprint. He talks about breaking down silos, or at least communicating between silos better than we do, and empowering one another. Maybe Ted's wrong about lots of things, but I think he's right about many things as well. This brings us to the point of something that's really become relevant over the past decade, something we call psychological safety. Ted's boss is Rebecca, and he started bringing her biscuits. What did he do this for? It was ordered to sort of disarm her in a way, but also to build trust, to, to realize fear is not something that's a foundation of a strong culture. How can we show that we appreciate one another and at the same time, importantly, as leaders, accept our own vulnerability? So Amy Edmondson, who's a professor at Harvard Business School, and by the way, her husband is dean of Harvard Medical School, has brought up the concept of teaming, an active verb, meaning that in complex situations and unpredictable situations like healthcare, it's something that's always on the go, always on the move, always changing. She's also been a big proponent of psychological safety, again, in the context of a just culture within a highly reliable organization. How can we better perform in this complex situation with respect to teaming? What gets in the way? Yes, it may be our culture, but it's also us. We're afraid to make mistakes. We're afraid to take risks. We know that as successful individuals, the imposter syndrome is prevalent. None of us want to look bad. We don't want to look ignorant, incompetent, intrusive, nor do we want to seem negative. But doing the right thing is never the wrong thing. Ted is absolutely right. So we have to be able to open our mouths and we have to be able to take some degree of risk, realizing that failure can sometimes be intelligent. And this is a book that I carry with me all the time, Right Kind of Wrong, The Science of Failing Well by Amy Edmondson, because I think it's really to understand this is how we do change. It's not by being blameworthy, it's by being praiseworthy when it comes to failure, by testing hypotheses, by exploring new ideas, by testing new situations. Again, we still have to be accountable. So, getting back to the concept of a just culture, accountability is key, but also within the perfect balance of psychological safety. By doing so, it puts us into a learning zone. Yes, we have to be comfortable and avoid apathy and anxiety, but we really want to learn and be accountable for our situations. And Ted again utilized this concept when he talked about being a goldfish. Why? Because a goldfish doesn't have a long-term memory. It's able to walk away from things and not continue to blame oneself or be blamed by one another. It's by learning the mistakes do happen. It's about having that growth mindset and focusing on swimming forward, about going to the future. Whether we like it or not, burnout and mental health issues have become problematic in healthcare, but in everything that we deal with. We see something in every publication, on TV, any media, almost every day about the burnout and the way it's occurring. And I wrote this piece years ago because I thought I was burning out. I thought that I was not enjoying medicine the way I had previously. I realized it was something called moral distress, but that's a whole different lecture in and of itself. So again, we start looking and focusing on things that may not necessarily bring us happiness, and we think it's how we've measured success. Is it salary and our job title? Perhaps we should be looking at other things, and yes, salary and job title might become components, but it's really important is our mental and physical health. And this means respecting ourselves as well as those around us. And Ted again exemplified this by bringing in Dr. Sharon Fieldstone, who was a sports medicine psychologist, to work with their team and acknowledge the importance of mental health by addressing burnout, by destigmatizing mental health and making it available to the team, and by prioritizing the whole concept of well-being. Now, I'm not going to read all of these statements to you, but this was a piece just this month in the Toronto Globe and Mail by a cardiac surgeon talking about how he broke down physically and mentally. He drifted around ghost-like, mourning the life that he once lived, but he didn't ask for help. I didn't reach out. I didn't know how to stop pretending because I pretended I was okay. And is that the way we're brought up as surgeons? Is it about being brave by not speaking up, especially against a culture of shame and blame? It takes bravery to step out of that environment and to challenge the status quo. A year ago, I was asked to deliver the first Blake Palmer lecture at the American Academy of Pediatrics. Blake was a friend and a colleague of ours, and now we're mourners. This is a piece from the Fort Worth Star-Telegram in an interview, his wife, Dr. Andrea Palmer. Nothing was out of the ordinary, but hindsight's 2020. She knew that Blake was a pleaser. Blake took his life. And how did Andrea react? The way many of us would. She had no forewarning, and she was angry. Now it's become sadness. She realized it was impulsive. And the question we have to ask ourselves, do we need to lose everything in order to find out who we really are? So self-caring is really, in essence, to changing our culture. So let's get back to the next steps, at least for someone like me and for Ted. How do we become mentors and coaches for the next generation? How do we make you more comfortable? Things are changing. Our profession is changing. It's a new generation, the way you learn in this room, the way you balance your own concerns and your lifestyle. We asked a question 20 years ago, are there too many pediatric urologists in North America? And reality-wise, the number of complex cases, or what we used to consider major index cases when I started training, have become part of the minutia of our care. I remarked earlier about groin and testis surgery and hypostadia surgery. Those have been the mainstays of our profession today in 2025. So is there a role for those of us from a different generation to impact some of the younger people in this group, some of the other active learners by coaching and mentoring? Realize some people follow the Dunning-Kruger effect curve and feel either overconfident or less confident. How can we impact those people to get them into the sweet spot? How will we define ourselves as surgeons? And again, this states academic surgeons, but it doesn't matter the environment in which you work. It's still, should we be coaching? Should we be mentoring? Should we be educating differently than the way we do now? So there is a future for all of us, and we have to keep changing with us because cultures are changing. The complexity is changing. And what I've learned from Ted Lasso, as well as along the way in my own life, is that we need to lead with empathy and truly be genuinely curious. We have to work within a culture of psychological safety and prioritize our colleagues and their well-being. We have to continue to collaborate and improve our communication skills. And as a result, hopefully, we continue to be innovative and see failures as opportunities and learn from them. So change is a good thing. We have to embrace it. Sometimes we have to brave in doing so, and by doing that, we can go forward. If any of you are interested, please email me at any time, but these are some of the publications that I've talked about during this presentation. And again, I'm open to any questions you may have at this time. And again, I appreciate the support of the Journal of Pediatric Urology and the American Academy of Pediatrics section on urology.